I hope everyone enjoyed that first session. It's always good in my mind to have a patient or family member come and remind us why we're all here and partially why we're so committed to working and making things better. So the next thing we're going to talk about, and I have the privilege of talking about this, is Sepsis 3. And I was fortunate enough to be involved in this process. So I guess I get the honor of being ridiculed or honored in one way or the other to talk about this here. So Sepsis 3 is our new definition. How many people are familiar with the fact that there was a new definition put out last year? Okay, so most of you. So this is a challenging area. So you probably are familiar with, I don't have any particular conflicts to disclose other than I obviously do a lot of work with sepsis and other areas. So I'm going to talk about the prior definitions, and I'll talk about the new definition, and I'll talk a little bit about what we understand the validity to be for this new definition. So first, conceptually, let's start off with what we remember sepsis to be. So there's some early definitions that came out, which I think are helpful conceptually, but don't necessarily help us at the bedside if you're trying to walk to the bedside and see a patient and be able to take care of a patient or identify someone that has sepsis. So thinking about these definitions, right, these are things that would help you think a little bit about what sepsis is, but it doesn't really tell you what you would use at the bedside. So that was really the impetus for the first definition, and I'm sure everyone's familiar with this one. This is the original definition from 25 years ago with the what we now call affectionately Sepsis 1, which set out the SIRS criteria. And we still use SIRS criteria. SIRS criteria have been the basis of what we've used for screening for sepsis, for managing sepsis, for clinical trials in sepsis, for epi studies of sepsis, all those different things. But it had a lot of flaws. So there was another group then that came along in Sepsis 2. And Sepsis 2 I find interesting because the rationale for Sepsis 2 was good in the sense that we realized the original definition didn't work as well as it needed to. There were a lot of patients who didn't meet the SIRS criteria but did have sepsis and vice versa. So they set out to try and improve that. But they realized fairly quickly that there really wasn't anything better than what they already had. So at the end of Sepsis 2, they basically said, stick with Sepsis 1. There's a bunch of things that we could throw out there. There's all these different parameters you could use, but none of them are really any better than what we have now, unfortunately. Now, with that in mind, it led to people beginning to think, well, okay, what are we missing here? What's still wrong? And clearly one of the pieces is that using the definitions we have, you get different results. So on the basis of just trying to identify patients, you get very different numbers of patients if you use these different definitions. And so the number of cases and the percent who die and all that really varies depending on what definition of sepsis you're using. And it led to people saying, well, we really need to think about a better way to do this. So that was the point of Sepsis 3. Now, part of Sepsis 3, and I'll show you this, but part of Sepsis 3 was also to make this more data-driven. So I showed you in Sepsis 2, they had all those parameters that they could use, and they said, well, we really can't espouse or recommend that you use those because they're not any better. But they really didn't know whether they were better because they didn't have the ability to derive a definition using those. So part of the Sepsis 3 process was to try and use data to derive a definition. So in Sepsis 3, the new definition is that sepsis is life-threatening organ dysfunction caused by a dysregulated host response to infection. That seems fairly complex. It's all fairly typical English language. I think we would all understand it, but there's a lot of sort of complexity to that. At the end of the day, there were a couple things that came out that were new. One was QSOFA. QSOFA was developed as a tool, which was, again, data-driven, using the data to derive these parameters. But it was developed in order to help screen for patients who might have sepsis. And it didn't tell you that they had sepsis, but it told you that these were people who were clinically deteriorating, maybe sick enough that you certainly should think about sepsis. You should think about whether they need early intervention, think about the proper care that these people need. And this is the low blood pressure, tachypnea, and altered mental status. Now, you might recognize that there's some things in here that are fairly obvious. One would be that if you present me someone who's hypotensive and tachypnic, you probably don't need to tell me that that person is deteriorating. I could identify that clinically. There's other parts of this that are data-driven that would say, well, but why a respiratory rate of 22, for instance? And the basic reason is that a respiratory rate of 20 is normal, technically. In every EMR that you ever look at, a respiratory rate of 20 is recorded for every normal patient. So it really has to be something abnormal. That doesn't mean that when you walk to the bedside, it has to be 22, but that's what the QSOFA score tells us. And when you validate QSOFA against other definitions, it really does perform well. So these are the three very simple criteria you can use. And the area under the curve, meaning sort of how well does it predict the outcome of someone not doing well, it really performs quite well. So if you're looking at people in the ICU, organ dysfunction scores like SOFA and LODS actually do better. That's probably not surprising. You're talking about critically ill people who are not really normal in terms of the blood pressure, altered mental status, and respiratory rate. But if you're talking about people outside of an ICU, where you would probably do more screening, it really does work quite well. Now, you could argue that SOFA might perform very similarly, but SOFA is a lot more complex, right? You've got at least 4 different levels of 6 different parameters. So you've got a complex score to create, whereas QSOFA is 3 parameters, yes or no. You can very easily walk to the bedside and use that. So are you familiar with the SOFA score? That's what it is, right? So you've got 0 to 4, 5 different levels of 6 different parameters. So every patient can have a score anywhere from 0 to as high as 24. For higher scores, obviously the risk of dying is greater, but to calculate this score is relatively complex, right? Sometimes it requires laboratory measurements, sometimes it requires going to the bedside and assessing the patient in some way. So there's things that you need to do that make it a lot more complex. At the end of the day, we also realize that septic shock is often what we're caring for. We need to be able to identify those people too. In the initial Sepsis 1 definition from 1991 and then the Sepsis 2 definition in 2001, there were definitions proposed, but they weren't really explicit. They sort of had conceptual definitions of septic shock, but not something that you could walk to the bedside. So Sepsis 3 tried to clarify that as well and said, here's a definition. The definition was intended to be those patients who are the subset of people who are more ill, have a manifestation of shock, and have a higher mortality. Clinically, that was defined as people who are hypotensive, requiring vasopressors with a lactate greater than 2. So that has a lot of validity. Those are the people with the highest mortality. These are the people we care about. We recognize that they need early intervention. We need to be attentive to those people and identifying them early. But at the same time, if you're in an environment where you can't measure lactate, you shouldn't necessarily ignore that patient, and you shouldn't say they don't have septic shock. If you have a hypotensive patient on vasopressors, that patient still, in my mind, would be a septic shock patient. But if you're really trying to identify and screen, you want to use all these different parameters together. Okay, so how does Sepsis 3 perform in real life, now that we're a year into this? Well, if you're looking at QSOFA particularly, which is one of the things that's been tested the most, we find that there's a few studies now. So these two came out very recently in JAMA. The FRONT study actually was comparing patients in the ED, so these are patients outside the ICU, and not surprisingly found that people who are QSOFA positive, meaning that they met at least 2 of the QSOFA criteria, those people had a much higher mortality. So if you were QSOFA negative, your mortality was about 3%. If you were QSOFA positive, your mortality was 24%. And the predictive validity of it was 80%. So it's similar to SOFA, but again, much simpler than SOFA, and it works quite well outside the ICU. Now, Wraith did this inside the ICU, looking at patients in Australia and New Zealand, basically using their administrative database. And what they found is that the performance of this was inferior to SOFA. But again, that's sort of what we originally knew when we proposed this, or when this showed up in the Sepsis 3 definition. We didn't say that it should be used in the ICU because we realized that the performance was inferior. So this is sort of validating that, yes, in fact, QSOFA is not the thing you should be using in the ICU. What about other parameters? Well, one of the things we've realized, for those of you that are pulmonologists or take care of pneumonia patients, there's a score called CURB 65, which is used for pneumonia scoring or your pneumonia prediction. That one's been used for a long time. So a group in China tried to compare QSOFA and CURB 65 in pneumonia patients and found that they work pretty similarly, area under the curve of 0.66 and 0.66. And if you use QSOFA, as you might expect, you're seeing a rise in the percentage of mortality with QSOFA. So the more QSOFA points you meet, the higher your mortality. And Henry Wang actually did something similar in looking at infected ED patients and showed that one of the emergency department scores performed the best. QSOFA actually performed the worst, but not necessarily hugely differently. So it sort of raises the question, well, is QSOFA as good in the subset of infected ED patients? Maybe not. Maybe we need to rethink that and try and come up with a better parameter for that. But it does tell us that all these scoring systems are actually fairly similar. And then finally, one of the things to remember is that organ dysfunction is the most important thing we're talking about here. So when you look at the new sepsis definition, the focus is on life-threatening organ dysfunction related to the host response to infection, right? So we can identify the infection, we can identify the organ dysfunction, And you have to think in both directions. So if you identify someone that's infected, you need to be thinking about organ dysfunction. That's the purpose of QSOFA, or if you want to use an early warning system or some other scoring system that you have built into your EMR or your health system, all those are fine. But you also, on the other side, if you find someone that has organ dysfunction, you also need to think about infection. And that's one of the other parts that comes out of sepsis 3, because that's the other part, particularly in the ICU patient, that helps us to identify the patients on both sides as quickly as possible. So now the other thing that I'll tell you, and you can see here, is that a SOFA score of greater than 2 reflects a substantial overall higher mortality. And so part of that, again, is to try and identify these patients as early as possible. And the goal here with sepsis 3 is to help us develop those parameters that we can use to do that. So, so the new sepsis 3 definition definitely has some new changes, right? So one of them is elimination of the word severe. Conceptually, we've always realized that sepsis was intended to be a severe condition which required urgent attention. So now we have sepsis. We don't have severe sepsis anymore. Mary still talked earlier about how do we deal with that from a compliance perspective. We're dealing with hospital management of patients and CMS guidelines for the SEP1 compliance bundle. That's separate. The sepsis 3 definition was really derived because we felt like there was a better place to go in terms of where we are in our understanding of sepsis. But it doesn't mean that we necessarily should immediately apply that for bundle compliance, because that's a different component of care. QSOFA, as I showed you in a couple of the studies now that have been done in the last year, really does work for screening patients. We can go back. There we go. QSOFA works well for identifying patients outside the ICU, probably in the ED, but certainly on the wards and in other settings. But if you're screening for patients in the ED, you really should be using something other than that. You can use it, but it's certainly not going to be as sensitive as using SOFA or maybe an early warning score or Apache or something that's going to help you identify the acute illness. And again, as I pointed out for septic shock, the definition is hypotensive on pressors with an elevated lactate, but that doesn't necessarily mean that you require that if you don't have the lactate, you wouldn't call those patients septic shock, right? So from clinical purposes, if we have patients in our ICU who are on vasopressors, who are infected and therefore in shock, those are septic shock patients. We're caring for those patients and we're wanting to care for them in the same urgent manner. If we had someone who was in septic shock with a lactate lower than 2, I would still treat them the same way, right? I mean, I guide some of my therapy towards that, but I would not necessarily not say they're septic shock. I would still treat them as if they're the septic shock patient. And again, I think we're going to see a lot more studies of QSOFA over the next year or two, and particularly some of the other parameters, right? So SOFA is one of the things that is the easiest way, we think, to identify organ dysfunction, because it is an organ dysfunction score. But there's a lot of places, for instance, in England, where they use early warning scores already now. They're embedded in their health system records, and those may be equally effective, right? So there's a lot of data now that says that early warning scores can help us to identify patients who are either deteriorating or developing organ dysfunction. That might be an effective way for some health systems to do this. So I'll stop there and take your questions.